Hi, my name's Chelsea. I am going to go over an axillary block with ultrasound and nerve stimulator today, followed by a TIVA with an LMA. So I have a 60-year-old female coming in for a left radial ORIF. She fell on an outreached arm. So our plan is an axillary block with TIVA. She's 66 inches, 66 kilograms. She has a history of Meniere's disease, osteoarthritis in her back, cardiac arrhythmias, hysterectomy and breast augmentation. She's taking hydrochlorothiazide, rovastatin, fomatidine, PRN, diclofenac, PRN, magnesium, vitamin D, and THC gummies at night. She's okay to continue these meds. However, the diclofenac she hasn't taken since Tuesday. And we recommended staying off of that just so that we don't have bleeding issues. I asked her if she had any history of bad anesthesia in the past. She said no. However, she is a lightweight, so we will try to use as little as possible. Her labs were all normal. I looked at her cardiac history notes. She had a stress test 3 months ago that was negative. Her EKG is stable. I talked to her cardiologist. They've approved her for surgery. Her METs is greater than 4. She walks 2.5 miles 5 times a week. On my assessment, her airway does not seem difficult. She's a Malampati 2, thyromental distance greater than 4, good TMJ movement, and good range of motion in her neck. Cardiac-wise, she didn't have any murmurs, good S1, S2 sounds, and sounded like she was in a regular rate. Pulmonary, she sounded clear. So I've talked to her about the risks and benefits. Risks for the axillary block being bleeding, intravascular injection, which could lead to LAST, and then the benefits being decreased post-op pain, decreasing the sedation that we need during the procedure, and she agreed to all these things. And then we talked about TIVA with the LMA, risk being that we may have to convert to an ET tube if needed. She could also have sore throat, post-op nausea, vomiting, dental damage, hypoperfusion to the heart and brain, which could lead to cardiac arrest, stroke, or death. And then benefits are amnesia. With that LMA and TIVA, hopefully she'll wake up easier without being on any gas. So she has consented, and I'm gonna go meet her in pre-op to do the block. She is already hooked up to monitors. She has a blood pressure cuff, a 3-lead EKG going, and a pulse ox on. I have already set up my OR that's going to be ready for me. I have all of my machine ready to go. My gases are full. My suction's working. I have my emergency meds ready. I have her induction meds ready. I have an LMA, and I also have airway equipment in case needed. I am going to get my nerve stimulator stuff ready. So I have an ultrasound. I have the nerve stimulator. For my meds, I'm going to use bupivacaine 0.25%, and I'm going to add 10 mics of Precedex to help extend the block. For her, we anticipate using about 20 mils, which is 50 milligrams, and that's well below our limit of bupivacaine toxic dose. I am going to go in with some Versed and fentanyl. So I'm going to do 2 milligrams of Versed, 50 of fentanyl to keep her comfortable. And then I'm going to give my ANSEF now just so that can start working. I have a nurse in here helping me who's going to aspirate and inject as I'm monitoring the needle location on ultrasound. So we're going to go ahead and position the patient laying down. We're going to put her arm up 90 degrees. She's already on the monitors. I've given the Versed and fentanyl. We are going to start up in the axilla as high up as we can, and we are looking for the axillary artery. Beautiful musculocutaneous. So we find that axillary artery. and compress to find the nerve next to it. This is a very vascular block, so we want to know where all of our structures are. Once we find that, so we would take our nerve stimulator. We have a grounding lead on the patient so that that works. We're going to start at 1 milliamp. We're going to come in from a lateral view or a lateral approach. We're going to come into this would be, we're coming in on the left side of the screen. We're going to go in starting at 1 milliamp. As we get closer to the nerve, we're going to turn down. We want to lose our muscle twitch around 0.3, and depending on what nerve we're at will depend on what twitch we're looking for. So we have our axillary artery, and around that we have the radial, ulnar, and median nerve. So our radial, we're going to look in the hand for a radial rotation, which will be the thumb rotating in. Ulnar would be the pinky rotating in, and median nerve will be our fingers flexing. So we'll be watching for those. We're going to start with one nerve. We're going to have the nurse aspirate back, make sure we don't have any blood, and then we're going to inject 5 mils at a time, watch for dissection around that nerve, and then we can move our needle again, make sure we get those other nerves, again aspirating first before we inject another 5 mils. Once we've done the radial, ulnar, and median, we will back out and get the musculocutaneous nerve, which sits between the coracobrachialis and the bicep muscle, and that one looks like a cat eye, and Marian's is beautiful, but you don't really have a great view. So once we have all of those all numbed up, we will go ahead and lean off our patient. And then we will roll her back to the OR. And once they arrive in the OR, we will have her help us move over to the table, and then we'll pre-oxygenate with 100% FiO2. We'll re-hook up our monitors, get some baseline vitals, and then once we've pre-oxygenated for 3 to 5 minutes on 100% FiO2, we can go ahead and do our induction. So we're going to do 50 of Fent, 130 of Propofol, and then I am going to take my LMA, which is nice and sleepy, get that in the back of the throat. I'm looking for misting in the tube. I'm going to hook up. I'll see an end-tidal CO2. I can listen for bilateral breath sounds, chest rise and fall. And then I just want to be sure with the LMA that I'm staying below 20 on the pressure, just so that we don't push too much air into the esophagus. And then I can tape my patient's eyes. For maintenance throughout this case, we are going to do TiVo with Propofol, 120 mics per kg per hour. And then titrate as needed. We'll have phenyl and ephedrine for hypotension if needed. And we may have to be on the ventilator mode just at the beginning after all the induction doses. And then we're going to let her return back to spontaneous breathing. The case is proceeding. Once we're getting close to the end, I'm going to give my 4 of Zofran, 4 of Decadron, IV Tylenol, and then I could do Toradol if needed for some post-op pain coverage. With the LMA, once I turn off my Tiva Propofol, we should be able to extubate or take out that LMA, or if she was still occluding, you could go over to PACU with the LMA in place. It'll just work as an oral airway. So for her, she is breathing spontaneous, everything is adequate. We're just going to pull out that LMA before we go to PACU. And I have an oral airway in pocket. I have extra fentanyl and phenylephrine in my pocket as we go over to PACU. I'm gonna do pass off to the nurse and team taking over and let them know any antibiotics we gave, narcotics, fluids that I've given, and that they may need to finish giving. Let them know about the procedure, what kind of block we did, what kind of anesthetic we did, any issues that may have come up, urine output, if they had a Foley, and then I'm going to assess my patient, make sure that their airway is adequate, that their vitals are stable, ask the nurse and team if they have any questions, and as long as everything is stable and they feel good, I am ready to go